Perfect. Okay, to remind you, if you need to make the quiz up, go see Mrs. Schaefer in the Natural Sciences office. If you don't know where the Natural Sciences office is located, you go out the double doors, you head through the other double doors, and it's the very first door to your right. Mrs. Schaefer comes in about 8:30. She leaves between 3 and 3:30. So she's here a lot. So finding her is not an issue. She takes lunch 12:30, but she usually eats lunch at her desk. So she's not hard to find. So find her and she will administer the quiz to you. Please try to make it up before the end of the week if you can. If you just can't find Mrs. Schaefer, if time ends up being a big issue, let me know. I will have a quiz for you to take, and that's the way that should work. All right. Quiz by and large went pretty well, so go team. And don't forget, we'll have another one this coming Friday. I realize with the snowstorms and everything like that, sports schedules are getting juggled, games are getting displaced and replaced and what have you. So just let me know and keep me in the loop. And if you miss a Friday, you can make up the quiz on a Monday. Not an issue. Just let me know. All right. Okay, we were talking about dosing when we ended last time. We'll back up a little bit, re-talk about dosing, and then get into loading doses and then other pharmacokinetic issues, and then we'll get into drug biotransformation, which is the means by which drugs are eliminated from the body. And okay, let's have a word of prayer, then let's begin. Lord, we are so grateful that you have deigned to redeem us with the precious blood of Christ, who is a lamb without blemish or defect. We thank you that it is not with perishable things we have been redeemed, but with imperishable things. Thank you for this week. Thank you, Lord, that it was a tad warmer yesterday. And now as we go into this week where it's supposed to stay pretty cold, we pray you'd help us be wise and bundle up when we need to and stay warm. And thank you for every student here, even though this is a small class, they clearly want to learn. So please, Lord, help us do just that. In Jesus' name, amen. All right, so the target concentration, that's this concentration in the bloodstream that gives you your therapeutic effect. That will give you the therapeutic effect while giving the lowest amount of or number of side effects. That's the concentration for which you're shooting. There's several ways to get it, as we saw with this type of graph. A intravenous infusion, constant infusion, kind of gives you this constant, very nice, stable concentration of drug. That's great if you're in the hospital or the doctor's office. Once they go home, you want something oral. Oral, as you see, will give you more peaks and troughs, but your average concentration is still the same. That's with 24-hour dosing. This is with 8-hour dosing. The more often you dose, the lower the distance between your peaks and troughs, the lower the peaks, the less high the troughs. But it's less convenient. People have to remember to take a pill 3 times a day rather than once a day. So the bottom line of all that, regardless of the manner in which you administrate it, your average concentration in the body is still the same. So to calculate a dosing rate, the dosing rate is the clearance rate, total clearance rate, times that target concentration. And to remind you once again, there's a set of tables in your notes that gives you some of these numbers for various drugs. I don't require it for you to know any of these numbers, but it's just to show you that these numbers are often, they're not made up. They're something that's calculated quite carefully from clinical trials. And this is also to show you that these are things you can calculate if you know the numbers. And the numbers are published. So clearance rate times the target concentration, that gives you the dosing rate. Then you get the maintenance dose, you take the dosing rate times the dosing interval, that gives you the maintenance dose. And just this sample calculation, if that's your target concentration for theophylline, that's our mean clearance. And then if the intravenous dose, of course, F means bioavailability. That's what, when you see F in a pharmacological equation, that's a bioavailability. Yeah. No, no. Maintenance dose is what's required to get that lag time. Now, where it will vary is with anesthetics, because with anesthetics, you have something called initiation and then maintenance. Initiation of the anesthetic state requires a higher dose. After you initiate the anesthetic state, then you go to a maintenance dose, which is lower. You think of a drug where that wouldn't be the case. Usually not for gases, because gases usually aren't used for maintenance. Gases are used like seroflurane, stuff like that. You don't use those for maintenance because they irritate the airways after you use them for too much, for too long. So usually use them to initiate, then you turn the gases off and just use the IV drugs. Yeah, for all those, the drug that's used most commonly for anesthetics now is propofol. Propofol, you have an initiation dose and then a maintenance dose. Usually like that. For a drug like an antidepressant, that's the case where the drug needs to build up and cause changes in gene expression in the body before you get the final therapeutic effect. That's why it takes at least a month for those drugs to start working. You don't start with a high dose now. they're anti-seizure meds. You'll step those up sometimes. So lamotrigine, for example, lamotrigine, you start here, then you go here, and you go here. Because it takes the body time to get used to it. You start here. You also, there's a phenomenon with drugs called Stevens-Johnson syndrome, where some people just react allergically to drugs and it's awful skin manifestation. You start, lamotrigine is one of the main offenders with Stevens-Johnson syndrome. So you step up to make sure that the patient doesn't experience Stevens-Johnson syndrome. That's the other reason you step up with that. Some antidepressants as well, you start low because some people respond to the low concentration. And if they respond, then you don't step them up. So bupropion, for example, Wellbutrin, you step up as well. That's to see if they respond at the lower concentration. If they do, you don't step. But usually they don't, and then you step up, and then you're usually at the final concentration. So that is more to see if they respond rather than to have it accumulate in the body. It's not really the same thing. All right, so we calculated our dosing rate using this equation before. And if we use these numbers for theophylline, target concentration, and then the clearance, that's the total clearance for theophylline. This is essentially the rate that you would infuse into someone intravenously. If we then want to, we see that for a intravenous drug that the dosing rate is equal to the infusion rate. And now if we want to give them an oral dose, we have to divide the dosing rate times the bioavailability, then multiply it by the dosing interval. And the dosing interval in this case, say we wanted to dose every 12 hours, twice a day. We get that number. If we wanted to do it for 24 hours, then we do it for 24 hours. 8 hours, we do it for 8 hours, so on and so forth, and you should get numbers. So the 24-hour dose should be twice the 12-hour dose, and the 8-hour dose would be 2/3 roughly of the 8-hour dose, of the 12-hour dose. Now, this kind of goes to your question, Bracken. Say you have a drug with a long half-life, someone is really suffering. Say it's pain, say it's asthma, say it's whatever. You want to bump them up essentially to that target concentration really quickly. You don't want to wait for the infusion. You give them what's called a loading dose. Loading dose would be essentially a bolus of the material, of the drug, essentially to get them to the target concentration. And while that bolus is waning, the infusion now starts to come online, so you get constant relief of whatever the ailment is. Loading doses are used in hospitals if somebody, their blood pressure spikes way up and they're going to have a heart attack. Their heart rate all of a sudden goes way up and you need to bring the heart rate down. Their pain level all of a sudden just really shoots up because they woke up or something like that. So you give them a loading dose while you're infusing the painkiller in or something like that. To calculate a loading dose, once again, you're going to use the target concentration, but you multiply that by the volume of distribution. Ways to estimate the volume of distribution I gave you those on page 5 of your handout. So these are essentially what you use for volume of distribution. Most of your HES, well, all of your HES majors, when you want to do an experiment with someone and you're looking at aerobic activity, what sort of measurements do you take of the subject? Heart rate, do you weigh them? Do you do body fat content? Yeah, these are all ways essentially that you can use to estimate volume of distribution. So if you're giving them a supplement, if they're on a medication or something like that, all those measurements that you're used to taking anyway, as a cardio rehab person, as a health coach, as a whatever, these are all ways you could use to estimate the volume of distribution. So you use that times the target concentration to get the loading dose. If you're giving some sort of intermittent dose, you're giving some drugs. Do you know what IV push is? And have you heard of it? Well, Bree, you have. But so IV infusion, you have a bag, you hang a bag, you have a needle, you put it in, and they get a constant infusion, usually by gravity, or if you want it to be really constant, you use a pump. And the pump essentially has a constant rate that's going into the patient. IV push, you have a certain amount of drug you're giving it with a syringe, you put it in the needle and then you slowly push it. That's why it's called IV push. You're pushing the syringe that has the drug into the patient. So they're getting a bolus essentially of this drug right away. And you're pushing the drug at certain intervals. There's a general anesthetic called etynomide. Etynomide is a very good anesthetic, but because it tends to suppress the adrenal glands, you don't give it continuously, you give it IV push. So if you want to so you only use it usually for short procedures. So you start the IV, but then you hook it to the etynomide comes in a little vial. You mix it up, you put it in the syringe, and then you give it push, and then that puts the patient out usually for about 15 minutes. Then after 10 minutes, you need another 15 minutes, you give them another push. So that'd be an example of an intermittent dose. An intermittent dose. Then you use the loading dose. In that case will be the maintenance dose time the accumulation factor. And that's also measured for drugs, which will usually be in the literature with the drug as well. So you choose a target concentration. You choose it on the information, based on the information available to you. You predict the volume of distribution and the clearance. You calculate your maintenance doses, measure the patient's response, and if you need to, the drug concentration in the blood. You revise based on these measurements, and then you rinse, wash, repeat to achieve the best target concentration. That's kind of the way you do that. In most cases with adults, the medications that are used, the kinetics is very well understood. This is usually not followed. Where this is something that you will need to apply is usually with babies. Because babies have a metabolism in a kidney that's coming online. And as the baby develops, those things come more online. And because kids develop at different rates, yes, they have milestones and things like that, but their development tends to kind of do this. So when you work neonatal or you work pediatrics, you have to calculate these essentially for every kid. You just can't assume. And so where you'll really do a lot of this is with kids, usually with little ones. Some variables to consider when it comes to pharmacokinetics. Drug absorption. What if you have a patient with an inflammatory bowel disease, like Crohn's disease, ulcerative colitis, something like that? Crohn's disease causes scarring in the GI tract. Is that going to affect absorption? Does scar tissue absorb anything? No. So you have a patient who's had Crohn's disease, say, for 20 years, and a good bit of their GI tract is scarred up. What's their absorption going to be versus someone without Crohn's disease? Okay, yeah, right, right, a lot lower. So oral drugs in that case are not going to be absorbed as well. That's something to consider. What if somebody has inflammatory, irritable bowel syndrome, but they have irritable bowel syndrome comes in M, mixed, C, constipation, or D, diarrhea. So if someone, say, has IBS D, materials tend to go straight through their GI tract. Their absorption in cases like that is also going to be lower. What if someone has IBS C, constipation? What's their absorption going to be like? Because the drug is going to spend more time inside the GI tract, so have increased absorption. What if someone's had bariatric surgery? Now what's their absorption going to be? Sometimes way down, depending on where the drug is absorbed. If it's absorbed in the early part of the small intestine, then the drug may not be absorbed at all. And you may have to, instead of using oral formulations, may have to use sublingual, transdermal, rectal, other forms in order for it to properly be absorbed. In older people, the absorption goes down, but the GI tract also slows down. So the drug will spend more time in a GI tract that doesn't absorb as well. So absorption stays about the same. So that's not something that tends to change a great deal with age. Clearance. The kidney function decreases about 1% every year after the age of 40. It's inevitable. It's just part of aging. So clearance in an older person is going to be low. If the drug is cleared renally, will be lower in an older person than in a younger person. So consider me, I'm 60. You guys are 20 or just 20-ish, something like that. You guys probably have, your clearance rates are 60% higher than mine. So I'm going to clear a kidney excreted drug much more slowly than you guys are. If that's the case, then you may need to dose an older person down in such cases, especially if it has active metabolites, because the drug will tend to accumulate in an older person as where it won't accumulate in a younger person. That's something to consider. Also, what if someone has renal disease? Now the drug is going to have a hard time being cleared at all. Same thing if the drug is cleared hepatically and they have liver disease. Another thing to keep in mind as well. Volume of distribution, as you get older, your lean body mass goes down. Muscle tissues, they get marbled. That's the term that's used. Because you have greater amounts of body fat, less amounts of lean mass, regardless of how hard you might work at it, that means that fat-soluble drugs are going to tend to get deposited in more of that marbled tissue. That won't be the case for a younger person, but it will be the case for an older person. You'll tend to depot fat-soluble drugs, therefore. So fat-soluble drugs then are going to need to be dosed down in an older person where they won't need to be dosed down in a younger person. And then half-lives. Some half-lives will vary from person to person. I'll just use one particular group of drugs as an example. There's a group of drugs that they're used mainly for anxiety. They're also used for catatonia, and they're also used for sleep aids and nervousness and things like that. They're called benzodiazepines. So benzodiazepines, there are short-acting, medium-acting, and long-acting benzodiazepines. The most famous long-acting benzodiazepine is diazepam. goes by the trade name Valium. Valium is a good anxiolytic. It's also used as an anti-seizure drug, and it's also used as a muscle relaxant. Valium has a long half-life. I'm very proud of this one, so I will share it with you. So one of the best ways to classify the benzodiazepines, you guys remember Tom Cruise years back was married to Katie Holmes, and they had a long divorce. It was in the tabloids. Remember, Tom Cruise was about as tall as Katie Holmes because he's not that tall. So TOM are the three short-acting benzodiazepines: temazepam, oxazepam, and midazolam. And then Katie Holmes, CAT, CAAT, so clonazepam, Ativan, which is lorazepam, alprazolam, and tozepam. And then, so short Tom, medium CAT, long divorce. Tom, CAAT, medium ones, long divorce. Long V, Valium for diazepam, and then chlordoxabine and E for irazepam. I'm very proud of that one because I actually used pop culture for that one. So that's the way you remember the short, medium, long-acting that benzodiazepines. Now, benzodiazepines can penetrate the blood-brain barrier. That's one of the ways they're able to deal with anxiety. Penetration of the blood-brain barrier depends, in most cases, upon their buildup in the blood. In an older person, because many of the medium-acting benzodiazepines are fat-soluble, they're going to be able to get through the blood-brain barrier much more rapidly. And if they build up in the bloodstream, they're going to cause you to be, I don't know how else to say it, to be drunk. Because your gait's going to be off, your speech is going to be slurred, ataxia is one of the side effects, movement issues. You'll look like you're drunk, essentially. So people who get prescribed these, they're habit forming too, so you need to watch out for that. If you prescribe these to an older person, even at normal dosages, because they don't get rid of them that fast and because they tend to depot them in their body, that high level of drug is going to stay up there longer. And it's going to cause them to have these side effects where they're drunk. And then if somebody's driving while under the influence of these drugs, bad idea. Even worse, you combine these drugs with alcohol, big mistake. Big, big, big mistake. But someone might say, oh, I had it 2 days ago. But because they're older, the drug's still hanging around their body, and alcohol is now going to take the effects of it and make it much worse. So one drink may not affect them that much, but with that stuff in their body, now it does. Whereas with a younger person, that wouldn't be the case. So half-lives can vary according to age for some drugs. And because of this depoting in the marble tissue, that can affect the half-life. Benzodiazepines are just one example, but they're a really prominent example. That's why in older patients, you tend to stay away from benzodiazepines if you can. There are also some pharmacodynamic variables. For example, if you have surgery, you wake up, what's usually the first question the nurse asks you? None of you have had surgery? A bunch of athletes in this room, none of you have gotten injured and had surgery? You don't remember coming out? It was all a fog. The nurse usually asks you, how's your pain level? Do you have any pain? Does that ring a bell now? No? All a fog. Well, actually, Brooklyn, this might be a good example. Then what's the next thing they do? Come on, Bree. Don't you remember? Okay, you take vitals, yes, of course. But then they give you something to eat and drink. Because you had to be NPO, nil per os, no fluids or liquids by mouth before surgery. You had to be NPO before surgery, so you're usually hungry. Also, the anesthetics usually make you a little bit hungry too, once they wear off, because they suppress the appetite, and then when they wear off, your appetite usually comes roaring back. The other reason they're giving you that toast or crackers or whatever they're giving you, in Great Britain, they give you toast with marmalade, and the marmalade they serve is awful. I don't mind orange marmalade, but the stuff they serve in the British hospitals, if the anesthesia doesn't make you sick, that stuff will. But you have to put it on the toast, because the toast they give you is so dry, there's no way you'll get it down. They're trying to see if you'll keep it down. Why are they trying to see if you'll keep it down? Right, they're trying to see if you have any long-term side effects from the anesthesia. Some people could probably sit there and eat a meal from Applebee's and not have any effect. Other people could probably take one swig of water and it would come up. Why is that? Sensitivity to the drug. Why are they sensitive to the drug? Because some people have more receptors for certain drugs than others. Others have the same number of receptors, but those receptors get hyperactivated by the drug. This is called drug sensitivity, and it varies from person to person. So if for your pre-op, usually they'll come in and ask you, have you ever had any reaction to anesthesia before? Because if you have, then the anesthesiologist will come in and talk to you and say, we're going to try a really low dose for you just to keep you under, but we're going to keep the infusion. If you start to wake up a little, we're going to have to jack it up, but we're going to keep it low. That way you don't have this awful, or that she may say, we're going to just try another drug on you since this one didn't work. So, and if that doesn't work, if that you react to that badly too, then we'll just have to try something else as well. Yeah, so that's due to sensitivity. Sensitivity varies from person to person, maximum effect varies from person to person. Some people also have abnormal ways of handling certain drugs. Other people too have unusual allergies to drugs. Other people don't have, they have a sensitivity to a drug. It's not allergy based, it's just a sensitivity. So if you've got any conversation with Beth Ulrich, for example, Beth, with certain types of drugs, they just make her feel funny. And it's not based, and she can't take antihistamines and make it go away. It's not based in the immune system. It's just based on something that has to do with Beth. She's explained it to me and said, explain it to me, to which I've just had to throw my hands up and said, I don't have a clue. It's just some people have unusual metabolisms that handle drugs in a strange way. And so from this, you might want to write in your notes, we're all individuals. There's a orthopedist in Jackson named Timothy Ekpo, really nice guy. If any of you need a knee or hip thing, go see him. He's absolutely the best in Jackson. He says something that I think is just perfect. He says, I don't treat x-rays, I treat patients. Because sometimes you can look at an x-ray and go, ew, you're walking around with that, but the patient's fine. Yeah, I only walk on that, I run on that. He might give you a funny look and say, you walk on that? Yeah, I feel fine. Okay, you feel fine? I'm not going to replace your knee because you feel fine. Because I treat the patient, not the x-ray. And your clients, your patients, your whatever, they're individuals. The things we're going to learn are generalized from what most people have happened to them in clinical trials. Are there outliers? Yes. Might your patient or client be an outlier? Yes, because they are a, starts with an I, individual. Okay? An individual. And if you happen to react funny to something, don't apologize. You're an individual, right? Right? Thank you. Yes, I know it's early, but still. Now, there are groups of drugs that glom on to serum proteins. We'll see a couple of these. Well, actually, we'll see several of these. So the main protein in blood is albumin. Albumin is released by the liver. And albumin is going to have an affinity for negatively charged drugs. These negatively charged drugs will tend to bind to the albumin. So you'll have this reservoir of drug in your body, but it's only the free drug that is going to be able to work. And this is one of the reasons why some drugs will show a lag time, because you take them, they get in the bloodstream, they get bound by albumin. It's only the free drug that really starts to do that. Many of your steroid hormones are that way. There's a steroid hormone globulin that binds steroid hormone, and 90 some odd % of the steroid hormone in your body is bound by the steroid hormone globulin. It's only the free steroid hormone that actually has biological effects. Same thing with certain drugs like warfarin, like aspirin, so on and so forth. Alpha-1 acid glycoprotein is another serum protein made by the liver in your blood. This is going to tend to bind positively charged drugs. Positively charged drugs. And some of those drugs will depot in the bloodstream because they're bound to this particular protein. Now, let's consider something. Since the liver makes these proteins, what's going to happen in someone with liver disease? So you have a patient who's an alcoholic. They're in early stages of cirrhosis. What's the concentration of these proteins going to be in their bloodstream? They're going to be the same, higher, or lower? Lower. If they're lower, then they're not going to be able to bind quite as much drug. That means standard concentration, standard dosages of those drugs might very well be too much for them, because you're expecting a percentage of the drug to be taken up by these serum proteins. What's left over actually ends up being available for treatment. Well, with this patient, that standard dose now, a lot less of it's being bound up by the bloodstream. So that is now going to potentially poison the patient. So that's something to consider. You may need to dose the patient down. Protein binding has a certain level of drugs it can handle. So there's capacity limits to it. And so if you take two different drugs and both of them bind to serum proteins, if serum proteins are already well bound by one drug, then the other drug, you might need to dose it down because all the drug binding sites are already occupied. That's something to consider when you're adding one drug to another and they both bind serum proteins. So consider the dosing history. Maybe someone did pretty well on a certain dose of a drug, or that dose didn't work. Other things to be aware of. This is just to show you how human scientists are. So there is an antipsychotic drug called ziprasidone. So ziprasidone came out, FDA approved it, but it was only slightly effective versus placebo, even though the FDA had approved it. Well, then a group at Yeah, it was Harvard. It was a Harvard group. Looked at the structure of the drug and they said, this is pretty lipid soluble. I'm going to bet this drug has to be given with a high fat meal in order to be well absorbed. So they conducted a trial, two groups. One group, they gave them a high fat meal with the ziprasidone, the other, they didn't. The people who took the high fat meal, the drug worked 3 times better than those without the high fat meal, and the drug concentration in the people who tried the high fat meal was now at the target concentration as opposed to those who didn't. So virtually all the clinical trials with ziprasidone before that study were deemed to be rubbish because the drug was not being absorbed, because the drug was lipid soluble, had to be taken with a high fat meal. Now, every psychiatrist will tell you, okay, when you take this drug, take it with a high fat meal. Take it with, oil on your salad dressing. Take it with high fat milk. Take it with, whatever. That will help you absorb it. That's just one example, essentially, of how certain things sometimes can influence whether or not your drug will actually work. And if you have instructions as to whether or not a drug should be taken with food or without certain foods or something like that, pay attention to that because that's important. Brooklyn?
When I went under, I had eaten for like 3 to 4 hours prior, just because I wasn't expecting to go under anesthesia. And I ended up getting sick after. Do you think that was because of the food or because of the actual?
Well, I'm not a prophet or the son of a prophet, but if I had to give an educated guess, I'd say the food had something to do with it. Were you also given paralytics with the anesthesia? Did they give you something to paralyze you? Were you given succinylcholine or something like that? What was the procedure, if I can ask? You had paralytics. You had paralytics. Yep, you had paralytics. If for that, because you work on a muscle, muscles will start twitching, and it's hard to work on them when they're moving. That's, yeah. Clonus is very common after anesthesia. It's like you're shivering, and that wears off. In fact, for propofol, that wears off quite quickly. But that's very common. But usually for something musculoskeletal like that, you'll be given paralytics. Those can make you sick too. So my guess, first of all, they should have told you not to eat anything at least 8 hours.
It was kind of just like a last minute. I wasn't really expecting to dislocated my ankle.
No.
So I ate dinner. I had to go to the hospital.
The food, I think, is a contributor. My guess is that you're probably slightly sensitive to anesthesia. But I need to know what happened if you actually went 12 hours NPO before the procedure. So I would think the food had something to do with it. But the fact that you're probably also given paralytics is another feature, because the paralytics, they tend to slow down your GI tract too. And then because food is normally used to moving through things just sit there, and that tends to make you a little sick as well. So that'd be my guess. But again, I'm guessing. Okay, so the body weight, use the body weight essentially for volume and distribution. Correct it if you need to, using percent fat and things like that. Now for clearance, fortunately, you can use creatinine clearance. Creatinine is a breakdown product of creatine. Creatine, of course, is phosphorylated by creatine kinase. You get phosphocreatine that's used to regenerate ATP. And creatine is also a supplement that some people will take. It helps with recovery, doesn't help with strength. People say it helps with strength. And when baseball players started taking it, people were talking about, oh, this is helping them hit home runs, to which I used to read those columns in the paper and say, man, you guys are ignorant. Because it has to do with recovery. That's all it has to do with. Helps with recovery, definitely. Does not increase strength, very clearly. But creatinine clearance is a very good measure of kidney function. Whereas liver function assays, liver function tests, don't correlate with the ability of the liver to process drugs. You can't use liver function tests to measure the liver's ability to do with drugs, but creatinine clearance is a good way to measure the kidney's ability to do so. And here's the equation for that again. If I want you to calculate this on a test, I'll give you the equation. I don't need you to remember that. That's just, yeah. Very good. Are there any questions about pharmacodynamics before we get into, yeah, Brooklyn?
Not about pharmacodynamics, but what equations will we actually need to know?
So there is a list of equations, and when I say I want you to know them, I just want you to know how to use them. So on page 9, there's this list of equations, and these are the ones that I may ask, but I will always give you the equation. I won't ask you to remember the equation. I'm just interested in knowing how to use the equation. Okay, that's the set of equations I want you to know how to use. And we've used a few of them. I zoomed today because I thought some of you were still out, but that's okay. It's recorded, so. We talked about how the liver is one of the biggest players when it comes to drug metabolism. Let's now talk about the metabolism of drugs in more detail. So sitting in these chairs right now, you are being exposed to chemicals from the carpet. Those are chemicals that are the result of the manufacture of the carpet. Also the cleaners that are used to clean the carpet. You're breathing those fumes in right now. I noticed Bree there is using a pen. She's actually breathing in some of the volatile molecules from the ink. She can't smell them, but she's still breathing them in. Her skin actually is taking up bits and pieces of the plastic as she rolls the pen between her fingers. I'm gonna make you self-conscious, aren't I? Bree probably washed her hair. I don't know why I'm picking on Bree so much, probably because she's easy to pick on. Bree probably washed her hair this morning with shampoo. She probably, some of that shampoo, fumes from it, she probably breathed some of that in, and some of that probably came into her bloodstream through her skin. Bracken today probably washed his hands with soap, and some of that soap may have actually gone through some of his pores. It's in his skin right now. If any of you use hair products or lotions or perfumes or aftershave, you're breathing some of that in. You're sitting on these chairs right now. There are chemicals from those chairs, from the cushions. You're breathing that in right now. I'm not trying to make you paranoid. I'm just trying to see we're exposed to untold numbers of foreign chemicals every day. And these are called xenobiotics. Fortunately, our body deals with them very well. And so really what we're going to talk about is what's the body do with them? Bracken, you had a question? That was your question. Yeah. Well, there you are. I made you paranoid in the process. So you're exposed to these every day. So I grew up on a farm, and my dad used to take me out, and he said, today, Michael, we have to spray for leafhoppers. So leafhoppers are this bug. It's about that big. It's a little triangle thing, of course, with 6 legs, because all insects have 6 legs. And they tend to hop from leaf to leaf, and they have piercing mouth parts, and they pierce the leaf, and they suck the juices from the leaf, and they will cause the leaves to wither, and you don't get good grapes from withered leaves. So we used to go out and we used to mix chemicals We used to have to put on these Darth Vader suits. They were called white capsule materials. And we'd take the stuff and we'd put it in, we'd mix it up, and then we'd pour it into this big drum on the tractor. And then Dad would hook it up, and then he'd drive the tractor through the fields and would spray essentially on the fields. And no matter how careful we were, I'm sure some of those chemicals got in our body. Now, the drug we used was malathion. Fortunately, malathion is not very toxic. But some of the other stuff that we sprayed on our grapes, some of the nematicides to deal with nematodes in the soil, some of that stuff now is banned because some of that stuff is potentially pretty nasty. I'm sure I got exposed to it. But those are examples of xenobiotics. So your kidney is going to excrete most of these things, but the kidney can only excrete things that are soluble, water soluble. What if they're not very water soluble? Now it becomes the job of the liver to chemically transform that molecule into something that's more water soluble so the kidney can excrete it. Sometimes this biotransformation will actually detoxify a potentially poisonous substance. Other times it will inactivate a potentially poisonous substance. The minority of times, however, this biotransformation actually makes the substance worse. And we'll talk about a few cases like that. Now, we discussed the first pass effect, the fact that many drugs that are administered orally, because after they're absorbed by the cells of the gastrointestinal tract, they go straight into the bloodstream, that blood supply that is drained by the GI veins, those main GI veins, the mesenteric vein being one of the big ones, gastric vein, what have you. These then all drain into the hepatic portal vein, which goes to the liver. And the liver then will biotransform some of these drugs such that their systemic concentration is so low, they never have a chance really to have any sort of systemic effect. What are these biotransformations that these drugs will undergo? These transformations can be put into two categories, phase 1 and phase 2 biotransformations. Usually, the phase 1 transformations occur first, and the phase 2 transformations occur next. There are exceptions, however. Some drugs don't undergo any transformation at all, and they just get excreted as is. Lithium. Lithium is pretty small, and your liver really can't do much with it. Also, lithium is already very water soluble. Lithium, goes straight through. Doesn't get changed very much. The trend is that the drug will go from being more fat soluble to more water soluble. That's a trend, and you see that trend pretty universally. Now, drugs may undergo phase 1 metabolism and have a metabolite with some activity. That then will undergo conjugation, typically by phase 2 reactions, and then it'll be eliminated. Other drugs, after undergoing phase 1 modification, may then be transformed into a metabolite with no activity. That then gets conjugated and then goes straight through. Now, there are some drugs that do not undergo phase 1 metabolism. They go straight to conjugation. And so once you conjugate, essentially, the drug, it's very, very water soluble and then just gets excreted straight away. So as we said, the phase 1 reactions tend to occur first. There are exceptions. Here's one of them. So isoniazid is a drug that's used to treat tuberculosis. This drug will undergo a phase 2 reaction called acetylation. You add an acetyl group to the nitrogen right here. Then it undergoes phase 1 transformation where you hydrolyze this molecule here. You add a water across this here. This gives you this benzopyridine, and then this molecule here, acetoacetate. Acetoacetate is quite toxic to the liver. Also, the rate at which some people acetylate isoniazid varies from person to person. There's some people that are called fast acetylators. They inherit that ability. For fast acetylators, isoniazid is very toxic at usual doses. They need to be dosed down. At standard doses of isoniazid, this hydrolysis is usually very slow. So you get so little of this, the amount of hepatotoxicity is usually not a big deal. So this is something that's of concern. The thing is, you don't want this intermediate to build up in the body. So that's why isoniazid is given at a particular dose that prevents this from building up. If you're a fast acetylator, though, this intermediate will now build up. So that's one example where phase 2 reactions occur first, followed by phase 1 reactions. We'll look at another drug where phase 2 reactions occur first, and that's acetaminophen. So do the phase 1 reactions inactivate the drug? Many times they do, but not always. Some drugs are prodrugs. They're transformed into the active form. So the drug that is used for gastroesophageal reflux disease, or GERD, you may just call it acid reflux, omeprazole, other drugs like omeprazole, esomeprazole, pantoprazole, rabeprazole, your mother-in-law prazole, those are prodrugs, and they are activated into the active form. Codeine. Codeine is a painkiller. It's transformed into morphine. That's a prodrug. Hydrocodone. Hydrocodone is also a prodrug. It's transformed into hydromorphone, which is the active form. And those are both analgesics, painkillers. Other drugs have active metabolites. They themselves are active, and they're transformed into a metabolite that is also active. So the antihypertensive losartan is converted into an active metabolite. Losartan with the active metabolite, therefore, has a longer half-life, reckon? They have the same response. One may be longer lived. That's definitely the case with fluoxetine. So fluoxetine, trade name Prozac, is an antidepressant. It's also used for generalized anxiety disorder, and it's also used for OCD, obsessive compulsive disorder, things like that. Fluoxetine is converted into norfluoxetine. And norfluoxetine has a really long half-life. That's why fluoxetine is given once a week, because it has such a long half-life, at least if you're giving it for depression. Other metabolites have, other drugs produce metabolites when biotransformed that aren't very good for you. Just one example is meperidine. Meperidine goes by the trade name of Demerol. Painkiller, very powerful painkiller. This drug works quickly and tends to be used up quickly. You only give meperidine, Demerol, for short-term purposes because this metabolite, normeperidine, crosses the blood-brain barrier and causes pretty profound neurological side effects. So that's an example of a metabolite that you don't want to build up. And it's particularly an issue in people with reduced renal function. That's something to consider. So the big gun when it comes to phase 1 biotransformation reactions are these group of enzymes called cytochrome P450s. Cytochrome P450s are found predominantly in the liver. They're also found in the small intestine. They're scattered through other places in the body. The kidneys got low levels of them. Gonads have low levels of them. But the place where they're concentrated the most is the liver. The liver. These are iron heme enzymes. They catalyze a multi-step reaction. This multi-step reaction is found on page 16 of your handouts. If you have that with you, go ahead and take a look at page 16. So that central iron in the enzyme plays a rather important role. That iron is going to help hold the drug. There will be other players. There'll be, for example, a flavoprotein. And that flavoprotein is going to act as a supplier of electrons. The drug, as you see, will undergo a transformation. Molecular oxygen will play a role in this biotransformation. And the iron goes through a cycle where it goes from a +3 to a +2 oxidation state. So this is a complex multi-step reaction. The thing I want you to see is if you have a writing implement, circle the molecular oxygen because that's important. These reactions require molecular oxygen to take place. Because they use molecular oxygen in this fashion, this is called a mixed function oxidase reaction. Mixed function oxidase reaction. The other piece I'd like you to know about these, and if you turn to page 14 and 15, you'll see that these enzymes are encoded by a multi-gene family. You don't have just one of these enzymes, you have close to 50 of them. And they're encoded by different members of the gene family that are named by biochemists, so the names are really boring. And they're called CYP 1, 2, 3, 4, 5, 7, 8, 11, 17, 19, blah, 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 blah. Then from these gene families, you have what are called isozymes. So you have CYP1A, and then there's a 1A1, 1A2, so on and so forth. So why do you have these different members of this family? They specialize in different substrates. And they're able to biotransform an extremely wide range of substrates. That's why you have such a large gene family of these. All right, we're out of time. We'll pick this up on Wednesday. Please take a look at page 14 and 15. I will tell you the ones that I really want you to be familiar with. Yeah, you can buy those from Mrs. Schaefer for a donation. Well, no, it's not a donation. It's a price. All right, gang, I will see you on Wednesday. Don't forget, if you need to take the quiz, go see Mrs. Schaefer.